morning, everyone. Today, we are going to talk about something new, that is some of the nutritional deficiency disorders among the children. We are going to talk. Before starting with the main condition, let me tell you what exactly these nutritional disorders or the nutritional diseases are. These are nutritional disorders. These are the diseases that occur when a person's dietary intake does not contain the right amount of nutrients for the healthy functioning, or when a person cannot correctly absorb these nutrients from the food. These nutrition disorders, they can be caused by the undernutrition, they can be caused by the overnutrition, as well as they can be caused by incorrect balance of the nutrients. So as I mentioned, the term malnutrition, right? So what is this malnutrition? So the World Health Organization defines the malnutrition as the cellular imbalance between the supply of the food or the nutrients and energy and the demand for them to ensure the normal growth, maintenance, and specific functions. So we finally reached a condition which we are going to discuss about today is the protein energy malnutrition, that is very common nutritional disorder seen among the children. So this protein energy malnutrition, it refers to an imbalance between the supply of protein and energy and the body's demand to ensure them the optimal growth and maintenance. This protein energy malnutrition, it's also called as the protein calorie malnutrition. This protein energy malnutrition, it's considered as the primary nutritional problem in India, so it's also called as the national nutritional disorder. This term of the malnutrition, it actually applies to a group of nutritional diseases. For example, the kwashiorkor, the marasmus condition. We'll see this marasmus, it occurs due to the inadequate intake of the proteins and calories, and it is characterized by the emaciation, that is the waste away physically, that is when the person's physique is wasted, the person looks very weak. Another condition which I mentioned is the kwashiorkor, which is the body's response towards the insufficient intake of the protein intake, and it is characterized by the presence of edema. Let's talk about the etiological factors for this protein energy malnutrition. The etiology for this condition is multifactorial actually. So the most common cause for this condition is inadequate of the food. The children with the low immune system, or we can say the immature immune system, has a greater susceptibility towards the infections. Gastrointestinal cause, which leads to the malabsorption of the proteins. The parasitic infestations, they play a major role in causing the malnutrition. In case of the very young infants, or I can say the young children, so for them, if there is lack of breastfeeding or they are having very diluted formulas, the complementary feeding among the children is very improper, and which may lead to the lack of good feeding technique. When the family is overcrowded or the family has the large number of children, ignorance of the children, or I can mention the negligence of the children. So because of that, the children are not being taken care of, so their feeding the nutrients, it's totally having a loss. When the parents or the family are very illiterate, they are very lacking to the nutrition, they are not having any kind of information regarding the children nutrition, regarding the what I mentioned is the importance of the nutrients. Lack of health education, it's a big issue that leads to the negligence of the children according to the nutritional needs. Due to the poverty, the parents, the family are not able to they are not able to meet the basic nutritional needs of the child. Infection can be the cause. Role of free radicals and aflatoxin poisoning, which damages the liver cells and gives rise to the condition kwashiorkor. Let's talk about some of the clinical features among this condition. Obviously, the clinical presentation will depend upon the type, the severity, as well as the duration of the dietary deficiencies. There usually are two main, the clinical features which you may be knowing, right? So these are the marasmus and the kwashiorkor again. We'll talk about the marasmus clinical feature. This marasmus, it's a very severe wasting of the muscles. It's characterized by the sunken features, the loss of subcutaneous fat, and the body weight. This condition will occur due to the deficiency of both the protein as well as the calories. So, what can be the clinical features of this marasmus? The growth retardation, as there is a great, the weight loss, severe muscle wasting, and the loss of subcutaneous fat, which results in the emaciation and the stunting. The skin of these children with this condition marasmus will be dry. It will be the scaly and inelastic, and it's very prone to infections. The hair of the child will be very hypopigmented and it will appear dull, and the brown or yellow color of the hair can be seen. The abdomen distension, which is due to the muscle wasting, and hypotonia will occur of the abdominal muscles. The mid-arm circumference, it will be reduced. Child definitely will be alert, but the child is very irritable. The face of the child, it will look like an aged look, that means the aged person's face, due to the loss of subcutaneous fat over the cheeks. Let's see the kwashiorkor, another clinical feature of the protein energy malnutrition. This condition is caused by the deficiency of proteins in diet. Some of the clinical features of the kwashiorkor are the failure to thrive. You can understand that, right? There will be much growth, the reduction, presence of edema. The face of the child will look like a moon face. The pot belly, or you can say the abdomen, the muscle wasting of upper limbs, but the edema of the lower limbs can be seen. Child will be peevish, lethargic, as well as listless and irritable. In these children, the fatty liver is easily seen. The nail plates of the children, they are very thin, they are soft, and they may be fissured very easily. The skin changes can be seen, and they are characteristic, and they progress over a few days. The hair changes, they are very prominent, and hair becomes thin, they become dry, and they can be, very frizzy. Loss of appetite is another feature which can be seen in these children. These children are also prone to infections, and they often suffer from the recurrent episodes of the diarrhea, the respiratory infections, as well as the skin infection. The diagnostic evaluation for this condition are: the WHO, World Health Organization, recommended some of the laboratory tests for diagnosing this condition. The first of the list, which comes as the health history, that means the nutritional history, the family history, as well as the history of birth, the history, of the parents. Then comes a thorough physical examination, which helps to find out, the disease with the help of some of the clinical features. Anthropometric measurement, it's to be done to reveal the weight for age as well as the weight for height. Then the peripheral blood film is taken to show the microcytic or the macrocytic red blood cells. Stool examination is to be done to find the presence of ova and the parasite. Then comes the blood hematology and the biochemistry, which may help to reveal some of the tests. The blood glucose estimation, which reveals the hypoglycemia. The serum albumin estimation, which reveals the serum albuminemia. Blood hemoglobin is to be done. That means the hemoglobin in the child will be low. Serum electrolyte estimation also is to be done. It reveals some of the the electrolyte imbalances. For example, the hypokalemia, the hypomagnesemia, etc. Serum cholesterol is checked, and definitely it will be very low. Blood pH is to be done for the metabolic acidosis, which can be present. Then the urine examination is to be done, which shows the decreased urine excretion of the hydroxyproline, reflecting the impaired growth and wound repair. Then, and final thing which we have talked about is the management of this condition, protein energy malnutrition. So this management of this condition, it is based on the following principle. The patient first is evaluated for the severity of the protein energy malnutrition and other nutritional deficiencies like the iron deficiency, which may lead to the anemia. Then the careful surveillance and promptness of the complications. Then promotion of the food intake, which helps in reducing the duration of the hospital stay and facilitates rehabilitation. Then the epidemiological factors which can be responsible for the malnutrition are corrected and attempt is made to eliminate these factors. So this management of protein energy malnutrition, it can be divided into two phases. The first phase is the initial phase. Then the second phase comes the rehabilitative phase. The first one comes, that is the treatment in initial phase, that is the from 1 to 2 weeks. First one comes the hypoglycemia. The child may have seizures or becomes unconscious due to the hypoglycemia, that you already know the level of glucose in the blood is reduced. For this, the 10% glucose should be administered in dose of 5 to 10 ml per kg body weight. The second comes the hypothermia. So the infants under 1 year of the age who are marasmic, they are prone to be hypothermic and they have the extensive loss of the subcutaneous fat, so they may be more prone to this thing. For this, the kangaroo mother technique can be helpful for such infants. The baby who is small is kept for incubator or the warm-up. Next condition can be treated as the infections. So depending upon the cause, the infection is to be treated. Children with the protein energy malnutrition, they are very prone to infections and especially septicemia, which is caused by the organisms like the Klebsiella, Salmonella as other opportunistic organisms. Antibiotics are given. It depends on the blood culture and the sensitivity reports. Aseptic technique and minimum of visitors may be useful in protecting these children from further infections. Then the next condition which is treated is the electrolyte disturbances. Children with protein energy malnutrition, they develop several electrolyte disturbances like hyponatremia, hypokalemia as well as the hypocalcemia. During the initial phase of the treatment, salt intake is restricted to prevent the sodium overload and water retention, which leads to edema. The severely affected children with the malnutrition with superimposed diarrhea or the infections which may develop hypokalemia, they must be treated with the potassium supplementation in the dose of 30 to 40 milliequivalent per liter. Hypocalcemia, it's managed by the calcium supplements. Then the condition which is to be treated is the dehydration. The dehydration should be corrected slowly over a period of 12 hours. The dehydration can be treated with the oral rehydration therapy or oral rehydration solution of 70 to 100 ml per kg. The intravenous fluids are given like the ringer lactate or the normal saline is given in dose of 30 ml per kg body weight. Initiation of the breastfeeding, which is very important to be encouraged. Feeding must be started. You know that after the fluid and electrolyte balance is corrected, then the breastfeeding is the thing which can be, the reason to get rid of the infections and which may be helpful in all other conditions. If the oral feeding or the technique is not possible, then nasogastric feedings are to be given to maintain the nutritional status. Then comes the second phase of treatment, that is the rehabilitative phase, which starts from the second week till 6 weeks. So, the management in the rehabilitative phase, the recovery of the weight which is lost, and therapeutic diet is very much important and it is to be provided. Emotional and the physical stimulation to the child. That means the human contact, the emotional support, as well as the tender, loving care. That is very important for the child's growth. The mother is to be trained for the domiciliary care. Then the preparation of the discharge after completion of the course. The recovery and the discharge, it may usually take at least 6 to 8 weeks for a child to recover fully. The child must be reviewed, that is to be followed up periodically from 8 to 30 weeks after the discharge. Let's talk about some of the preventive measures for malnutrition. Exclusive breastfeeding for first 6 months of the age is to be encouraged. After the completion of the 6 months of the breastfeeding, the weaning must be started at this age. Immunization must be done and completion of all the immunization, the doses to prevent the children from communicable diseases. The detection of the malnutrition at the earlier and the early interventions are to be taken. Growth monitoring is very important, which helps the track of the child's growth and development. Promotion of the nutritional education as well as the literacy in the community, which will be helpful to which will be helpful to create awareness among the parents, among the family members, to get into the nutritional states, to know more about the nutritional values and importance for their children. Provision of nutritional supplements for infants and the children by the government services. So here we end up with this, the terminologies like, for example, the protein energy malnutrition, which we have discussed today, right? So this is the condition of which lacks the proteins and the calories in the child's body, and there can be the imbalance between the food and the body's functions. And so there usually are two main clinical features under this condition, that's the marasmus and the kwashiorkor. So for this, the diagnostic evaluation, which depends on the cause, can be done, and after revealing the diagnosis, then the management according to that factor can be proceeded. Right? So for this, the prevention is very important, which you already know what can be the preventive measures, right? So I'll meet you in the next session with some more conditions. Till then, stay connected and stay safe.